The first committee hearing of the 2021 session is from our committee because I feel we have a huge impact on over almost 1 million of our senior residents across the state. This is the committee that deals with all of their issues, and it's truly an honor to be their voice here in St. Paul. And I've always felt it's our obligation in this committee to make sure that we protect our most vulnerable. So I think it's great that we're kicking off the 2021 session with the Aging and Long-Term Care Committee right out of the gate. Since this is our first committee of the new biennium, I thought we should each of us members introduce ourselves because not everybody knows each other. So I'll go first. I'm Senator Karen Housley. I represent Senate District 39, which is Forest Lake, Stillwater, and the surrounding St. Croix Valley. And I was just elected to my 3rd term and the 2nd term as the chair of this committee. We will go to the minority lead, Senator Kent Eakin.
Great. Well, thank you, Senator Housley and Madam Chair. And I represent District 4, which is up in the northwest part of the state. I have Moorhead and Detroit Lakes in my district. Those are the 2 population centers. It includes all of Clay County, all of Norman County, and a portion of Becker County. And this is like Madam Chair, I'm in my 3rd term now as well, and also my 2nd term now on the Aging and Long-Term Care Committee. Have enjoyed working with Madam Chair Housley and also with the other committee members. I too agree with Senator Housley that this is one of the most important issues we could possibly be dealing with, especially during the pandemic now, and protecting and providing care for our most vulnerable citizens. So it's an honor to be on this committee with all of you, and look forward to hearing from the commissioner and look forward to working with you. Thanks.
Thank you, Senator Eakin. Vice Chair Senator Curran.
Thank you, Madam Chair. Mark Curran, representing Senate District 32, most of Chisago counties, except for the one township that Senator Housley has taken from me. And in addition to almost all of Iceni County, except for a small portion in the southwest corner. And so this is my 2nd term, and also my 2nd term serving on the Aging Committee. And I'm excited and honored to, of course, be again on this committee. And so look forward to another great year. So thank you.
Thank you, Senator Curran. Up north to Senator Carrie Rood.
Well, good morning. I'm Carrie Rood. I represent Senate District 10, which is all of Aiken County and Crow Wing County. And Aiken County has the distinction of having the highest median age of any county in the state of Minnesota. So the aging population is really important to my district. I am in my 3rd consecutive term. This is my 4th term. I did serve from 02 to 06, and I took 6 years off to take care of my parents, who I took them on their journey in the myriad of care that we found. And so this is really important to me. They both passed at the ripe old age of 97. And so we used a lot of the different care, from assisted living to nursing home to memory care. And so it's really important for me that our seniors have good care and good advocacy, because I saw a lot of folks who never had anyone come to visit them and see them. And so it's really important that we be their voice in their advocacy. And I really compliment Senator Housley for understanding that and creating this committee, because it didn't exist before, and she insisted that we put this committee together to address that problem specifically. So hats off to you. This is my 2nd term on this committee. So thank you.
Thank you, Senator Rood. We will go to Senator John Hoffman.
Good morning, everyone. I something with passcodes and passwords to get on these Zoom calls are beyond my reach. I think I should be on the tech committee that Mark has, but I am John Hoffman. I live in Champlin, represent Senate District 36, which is Coon Rapids, Champlin, and Brooklyn Park. And it is absolutely a joy to be part of this committee once again, which I believe, when we focus on the intended outcome of what we're supposed to be doing. We leave politics aside, and it's just absolutely what you've done for 4 years, Karin. And I'm honored to be part of this group again. And just a little FYI, since you took a little bit of Mark's Senate district, did you happen to go through his Christmas light display this year? My God, you guys, it's worth every drive trip up there. So it's good to be back.
Thank you, Senator Hoffman. Yes, I have, and it's amazing. And I think he puts a smile on a lot of senior faces because he's got the assisted living facilities and nursing homes getting buses going by his, touring by his house every Christmas season. So thank you, Senator Curran, for that. And you make a lot of us happy. Senator Abler. Got on you. There you go.
Yeah, and it said, can you start my video here? Anyway, so it says you've disabled my video. Anyway, so I'll just talk. I've got a face for radio anyway, so that'll be good. I'm really happy to be here. Let's see what it says. Oh, start your video. Okay. You know, John, we need some 14-year-olds at home. I just saw 2 of my kids off to go back to Virginia, and they could have helped. Really happy to be on the committee. Thanks, Madam Chair, and I'm sorry I was a little late that we just saw them off. But so I think that, you know, when we look back on our careers and stuff, I think that a lot of us will be happy with the work we did on this committee, trying to help seniors and aging issues and spilling over into people with disabilities and protecting them so that people can feel comfortable that when they go into a place that they're going to get what they actually bargained for. And that they're going to be safe and well cared for. And we're actually a little ways off of that yet, which we'll be talking about, I'm sure, but really happy to be a part of it here. And so, we're introducing ourselves. Jim Abler from Anoka, I'm happy to chair the other committee that carries the money for this one. So we have a lot of work ahead, but I'm optimistic and I we'll get into some contact, some discussions, but I do want to thank Commissioner Malcolm for her leadership in some of these matters. I think it's a nearly impossible task, as we'll be talking about some of the challenges, but just thank you for who you are and the stability you've brought to this topic area, and look forward to working with you some more, and Madam Chair with you as well. Thank you.
Thank you, Senator Abler. And our newest senator, Senator Putnam. Oh, you're on mute.
It's like this is the first time I've ever Zoomed. What is this Zoom thing? My name is Eric Putnam. Thank you, Madam Chair. I'm senator from District 14, which is St. Cloud, St. Augusta, Haven-Minden Township, and Waite Park, basically Greater St. Cloud, the Greater St. Cloud area. This issue is one I'm glad to have the opportunity to work on. It's one of the committees I actively advocated for myself for, partially for political reasons, because it's very important to my community, but also for very deeply personal ones. Both my in-laws are currently in assisted living. My mother-in-law is in late-stage dementia, and both of them tested positive for COVID last week. So this is something that has compelled me for a very long time, and I'm really eager to have this opportunity to learn from you all and to actually do some good around these issues. I do have to make 2 quick apologies. Well, actually, first, this is not only my first year in the Senate, this is my first meeting of this variety. So be gentle with me. Secondly, I do have to leave a little bit early. I have concurrent meetings that I'd already scheduled weeks ago around 9. So I'm gonna have to leave a little early, and I apologize for that rudeness. And last, I have a brand new kitten who is in my study with me right now. So if I look pained or frustrated, it has nothing to do with our procedure and everything to do with the claws that are probably in my foot.
Perfect. Thank you, Senator Putnam. I saw the kitty going across your desk. You're going to have some big shoes to fill. Senator Jerry Ralph was a big part of this committee. He was our vice chair, and we're deeply saddened at his loss, but he was very passionate about protecting our elderly. So we're excited to be working with you. I'm sorry that your in-laws both got COVID. That is scary, scary, and part of the reason we're having this committee meeting right now today. So welcome, Senator Putnam, and we look forward to working with you. Committee staff, we do have a new CA this year. It's Susie Giroux. There, she just popped on her video. Hello, Susie. Thank you for working with us. Our CLA is Hannah Seitzer. Hello, Hannah. also my LA. And then our Senate Council again this year will be the great Liam Monahan. So thanks so much, Liam, for serving our committee. Thanks for working with us. In today's committee hearing, I want to focus on two things when it comes to our long-term care facilities and seniors living all across the state. One, where are we on COVID-19 testing? And two, what's the vaccination rollout for testing every senior over the age of 65 across the state? We all know that this pandemic has hit our seniors the hardest. It's very scary to get COVID as an older adult. We have more seniors losing their lives to COVID in our long-term care facilities than any other place in the state. And at one time we were in the high 70%. So it's a scary thing, and we need to be protecting these seniors. These residents have been cooped up for almost a year now with no regular family visits, no social events, no meals together. They're confused, they're lonely, they're depressed, and it's just gloominess all around them, and it consumes them. Many of their friends are dying, and many of them are dying alone due to this lockdown. They were not prioritized when the pandemic hit, and I know I was screaming from the rooftops, trying to have their voices heard. I didn't feel that they were prioritized when the pandemic hit, and many of the facilities went without PPE. Testing wasn't a priority. They were seeing people getting tested on street corners, yet they couldn't get tested in their facility. And many caregivers to this day are still putting in round-the-clock hours. They're already understaffed, and now these caregivers are completely depleted. So they want to make sure that they are going to be a priority in this next rollout of the vaccine, because now we have the vaccine. We have a vaccine, and it's giving these seniors some hope finally. They know that it's there, they've seen it on the news, but they want to know, when are they going to get it? They want to be the first ones because they are the ones that are most at risk. But what they're hearing is so many others are already getting it ahead of them. And we just want to make sure that we clear that up to make sure that they are a priority this time around. They're seeing prisoners getting the vaccine, or if they were in Florida, they could get in line. Anybody over the age of 65 could be getting it immediately. And seniors 65 and older that are even living in their own homes right now are calling their primary care physician saying, when can I get the vaccine? I've been cooped up in my house here forever. When can I get the vaccine? Only to be told that to check their local newspaper to see when the announcement's out, because even they don't know. So that's the focus of this committee. I want these seniors to be a priority, all of them. Everyone over the age of 65 in the state of Minnesota should be the top priority to get the vaccine. So that's why we're here today. So I want to welcome to the committee my friend, Department of Health Commissioner Jan Malcolm, and Infectious Disease Control Director Chris Ersman, here to present the plan for the rollout for the vaccine and how we're doing on the testing. Welcome, you guys. I have allotted about 40 to 45 minutes, 40 minutes. We have to be done by 9:15 if we could, so we allow the members for questions. So with that, I will turn it over to you, Commissioner Malcolm.
Great. Well, thank you. Good morning, committee members. I look forward to being with you in person if the fates allow before the end of the session. It's nice to see you again, and welcome to the committee. And thank you, Madam Chair. Thank you, Senator Abler, for your kind words. It's been a tough year. COVID has been a very trying experience for everyone in our state, and no one more so than our elders and people needing long-term services and support. We have a lengthy slide deck that we put together, not because we're going to go through every slide. We know the two focus areas that you want to talk about today, testing and immunization, but as a resource for the committee and the public, we put together this slide deck, which puts these two issues in the broader context of what we've been trying to do and have been succeeding at doing and with all respect to Madam Chair, this has been a priority for the health department since the beginning of the pandemic. So just wanted to kind of lay out for you some of what we've been doing since the beginning, but we're not going to spend time on that in today's hearing. So happy to do that though at any time, because there are many questions, legitimate, good questions that you have about prioritizing this population and what we've accomplished. So I'm just going to kind of orient you to what's in the slide deck, but not go through each one. My colleague, our legislative director, Lisa Timian, is on the line, along with Chris Ayersman, our infectious disease director. Also, Diane Rydrick, who is now the assistant commissioner for the Health System Bureau, in which health regulation and our long-term care activities reside. Diane's been leading in some of our long-term care testing efforts. So we're all here both to answer your questions, but to take you through kind of some brief progress reports as well. So Lisa, if you would advance the slides, please. The first couple of slides in the deck, and I believe you all have these, are just simply kind of set the context of what the goals have been for the pandemic response across the administration since the beginning, and some of the core strategies that we've used, which have included protecting the most vulnerable, making testing widely available, and of course, one of our goals from the beginning, but especially now that, as the Madam Chair said, we have the vaccine, our strategy now is to bridge to the point in time when everyone can be vaccinated, that wants to be vaccinated and should be vaccinated. It is a frustration, I will tell you right at the outset, that the vaccine supply is so very limited nationally, and is leading to a lot of these very real questions about who's prioritized, why do we have to prioritize, what's the schedule, what's driving the prioritization, and Chris can speak to those things. Lisa, are you able to pull up the slides?
Is it not showing now? Uh-oh.
No.
Let me try again.
Maybe you need to share your screen, or I'll just keep talking and we can just catch up with the slides. So again, sort of we sort of had these goals from the beginning of the pandemic to slow down the spread. We knew we couldn't keep COVID out of Minnesota, but slowing down the rate of growth has been absolutely critical, not only in order to prevent deaths and long-term health problems, which we now know more about, but also to avoid overwhelming the healthcare system, which continues to be a real concern. Some of our core strategies, as mentioned, have been focusing on the vulnerable and making testing available, and using data as best we can to provide guidance on mitigation and the ways to try to balance reopening of businesses wherever possible. We have
Commissioner, I'm sorry to interrupt. Can you all see my screen now?
Yeah, we can.
Oh, perfect. Okay, sorry to interrupt.
That's okay. So we have known since the very beginning. I think my first testimony was in the end of January, where we were talking about this, that we knew that long-term care facilities and residents would be at elevated risk just by virtue of age, the health conditions of these frail folks in our facilities, just the very fact of congregate living. And what this committee has worked long and hard on, and we all have much more to do, many systemic issues in this industry that have far predated the pandemic, but that the pandemic is shining an even brighter light on, the pre-existing staffing challenges in the industry. Then these next few slides, and I'm not going to go through them, just detail kind of what we have been doing since the beginning. As we stood up resources at the State Emergency Operations Center, coordinating with our healthcare systems and long-term care all across the state through something called the Statewide Healthcare Coordinating Center. And these next slides just kind of detail some of those early efforts from the very beginning, starting in February, March, and April. We started stepping it up in terms of our interface with the long-term care facilities. And the fact, as the chair rightly noted, in the beginning of the pandemic, PPE was in terribly short supply statewide. Long-term care was not even eligible for personal protective equipment from the federal strategic national stockpile. So Minnesota really needed to build up our own supplies and to not just have an acute care focus on who needed those supplies, which has sort of been the historical bent, but also to see that was in long-term care. And of course, in the early days, as the chair noted, Testing capacity for everyone was extremely limited. We had only 2,000 to 3,000 tests a day in March and April, and that's when the governor said we got to get to 5,000. Well, we've long since surpassed that, but that was in fact the situation early on in the pandemic: inadequate PPE, inadequate testing, lots of concerns with infection prevention in the facilities, lots of staff turnover, and just a whole range of systemic issues. Next one, please, Lisa. And so then, in May, after the first couple of months of difficult learning, the governor challenged us to try to really get even more focused on long-term care, apply some of those difficult early lessons with some of the facilities who were hardest hit early on, and to really step up our game on testing specifically, and personal protective equipment and support for staffing. So I'm going to turn it over to Diane Rydrick for just a very brief progress report, primarily on the testing, which was your question, but there are other slides in the deck that Diane won't spend time on, just giving you some statistics on progress on each of the elements of this plan. So turn it over to you, Diane.
Thank you, Commissioner Malcolm. Ms. Rydrick.
Thank you, Madam Chair. Again, for the record, my name is Diane Rydrick. I'm the director. I'm sorry. Oh, still using my old title. I'm the acting assistant commissioner of the Health Systems Bureau at MDH. And Senator Rood, I'm checking in from your district up here in Aiken County. So where it's lovely and snowy and sun's starting to peek out. So I'll just speak briefly to a couple of the testing slides, and I might just note a thing or two on a couple of the other elements of the battle plan, but I'll spend most of my time on the next couple of slides. So just as context, I want to note when we talk about testing in long-term care, it's not just about running the tests in the lab. It's not even just about the process of collecting the specimen or a staff person. A lot of the logistics of testing are the thorniest for facilities that are trying to get this done for their. As part of the battle plan, we established a process for them to let us know if they needed help. We have what's called a red cap tool through which they can let us know that they need a team to come out there to do specimen collection, or they need testing supplies and kits. We stood up a team to handle the scheduling and the logistics. If you have a lot of facilities that need testing on a particular day, you've got to figure out where you're sending your teams, and you've got to make sure that the supplies and the people get to the right place at the right time. We developed toolkits, FAQs, we've got sample consent forms, registration forms, toolkits, other things that facilities can use, and detailed guidance that helps them know what they need to do before a team comes on site. There's a lot of prep work they need to do, everything from how to talk to residents and families about testing, how to plan the flow of the day, where do you do the specimen collection, how do you set up for the team, how do you manage the storage of specimens so you keep the cold chain in place. For facilities that lacked a medical director, which many assisted living facilities do, we established a standing order that they could use to get tests for their residents or for their staff. And Dr. Ruth Linfield from MDH is the ordering provider in those situations. And we also contracted with a nurse triage line to then report those results back to facilities when they use the standing order. We started out using the National Guard to do specimen collection, and they first were deployed to that mission in early May, within, I think, a week of when the battle plan was announced. Over the course of the summer, we transitioned away from the National Guard to a group of health systems and staffing company contractors who go out and do specimen collection around the state. The National Guard transitioned fully out of that role, doing specimen collection at the end of the summer. But as you'll see in one other slide, they are still an active presence in long-term care in a different way now. Next slide. So this is where I'd like to focus a little bit more time. You know, as the commissioner noted, in the spring, there were only 2,000 to 3,000 tests a day that were happening statewide. But now a very significant portion of the testing that happens each day and each week is in long-term care. So over the last 6 weeks or so, the number of PCR tests being done each week in long-term care ranges between 45,000 and nearly 70,000 per week. And there are thousands more antigen tests. Those are the point of care, rapid turnaround antigen tests that facilities do using devices that have been provided by the federal government. A lot of that fluctuation between 45 and 70,000 tests per week is driven by CMS requirements. Excuse me. Skilled nursing facilities are required to test their staff at a frequency that is driven by county level positivity. So if the county's positivity rate for COVID is 10% or more, they have to test all of their staff twice a week. And when they drop down to the 5 to 10% range, they test once a week, and below 5%, they test once a month, in addition to any outbreak testing they do. So as we've seen county positivity rates really rise in the fall with the fall surge and now dropping back down, that drives a lot of fluctuation in the amount of testing that happens in long-term care. But I'll note that testing infrastructure that we built in the State Emergency Operations Center is still filling a critical need. So we coordinate still around 10,000 tests per week at about 100 facilities per week. And our projection for this first week of the new year is similar. So they are still coming to us to fill a critical need, even though we have now successfully built up a process where a lot of facilities are able to get their testing needs met on their own with a direct connection with a lab. So that team at the SEOC, as of the end of December, had coordinated testing for 883 unique long-term care facilities and nearly 270,000 people. So the number of people is not unique because many people get tested more than once, but 883 facilities is the unique number. So I'll just go through a couple of the slides really, really quickly. On slide 10, I mentioned that we've been providing case management support to facilities very early on. Sorry, the commissioner mentioned that very early on since the spring. That work continues along with infection control guidance and on-site visits for infection control, and having a team at the SEOC that is available to help facilities troubleshoot, connect them with labs and supplies, help them prepare, et cetera. Since the battle plan launched, the case managers have supported, it is now more than 1,600 long-term care facilities. I apologize, that number is about a week old and I wasn't able to get the update for today. And infection control experts have provided more intensive consultation on infection control and prevention to 340 facilities. We'll skip the next slide, I think, on PPE, but go to the following, which is, I think, what you really want to know about PPE. The commissioner mentioned in the early days of the pandemic, PPE supplies were really tight, and for everyone, not just long-term care, but all settings, it was unclear whether there were going to be ongoing supplies of PPE. So it was a challenge to get it out to anyone who needed it. But since that time, we've pushed well over 9 million gloves, more than 100,000 N95s, nearly 150,000 cloth masks, and around 350 gowns to long-term care. So once some of those supply issues were ironed out, we have prioritized long-term care and have continued to provide PPE to those who are getting to a point where they are starting to run short, along with providing them extensive guidance on how to use it effectively. So I will just touch very, very briefly on staffing because it is an issue that's very closely interrelated with testing. And just note that staffing crises have been a critical issue in long-term care, and especially in the fall wave of cases. We saw facilities that experienced sudden outages of high numbers of staff related to either positive tests or the need to isolate or quarantine related to an exposure. And that is closely linked to testing, especially once facilities started being required by CMS to do testing of their staff once a week or twice a week. We would sometimes see, as county positivity rates went up and as there was more testing, we would see facilities go from having stable staffing to being in a near crisis literally within a few days, because they could suddenly have 10 staff who test positive all at once, and they would need to figure out how to deal with that. And we ask them to first try and solve the problem locally. You can talk to a sister facility if you're part of a chain, use existing contracts that you have with staffing agencies, seek staff via the ALADTech database, which the state has set up, where you can find individuals who are able to take shifts, or through accessing the emergency staffing pool that DHS has operated. If those things fail, then that's where the National Guard comes in again. And we'll send out a team from the National Guard to support them. And those teams can be in place for as much as 10 to 14 days until staff return and the situation stabilizes. We've also been really fortunate to have some federal teams of nurses who have come to the state at different points in the spring and fall. Our final team of 15 federal nurses is finishing its final mission in Minnesota on Friday. And we don't know how likely it is that we will get another, but they have really been critical and they have provided support to a number of facilities. So I'll just note, if you can skip the next slide, which I think the commissioner touched on, and the last one that I will speak to at all is just some of the staffing metrics. This is an overview of the number of facilities that have been supported by those various routes at different stages in the response. So I will note, and my apologies, the number at the bottom, I should have updated and I missed that. The number of facilities that we're supporting through our crisis staff managers this week is 28, but 47 is the average that we had through October through late December when we really saw a fall wave of cases. And it was as high as the upper 50s a couple of weeks ago before we started to see rates coming down just over the last couple of weeks. But we had a period where we were supporting through these various means well over 50 facilities. And we're pleased to see that now we've come down quite a bit and hopefully that will continue over the next couple of weeks. So I will stop here and turn it back over to Commissioner Malcolm.
Thank you, Ms. Rydrick. Commissioner Malcolm.
Thank you, Diane. Madam Chair, would you want to take questions on testing at this point, or shall we go into vaccination and come back to questions after we're done?
You know what? Let's go into vaccinations and then we'll come back after we're done. Thanks.
Okay, very good. So the next few slides just kind of tell the story through data of what's happened during the course of the pandemic, but I want to talk about this one just for a second. Madam Chair mentioned this. Part of the terrible price that long-term care residents and their families have paid is the isolation that COVID has brought. It was an early strategy recommended by the national, by CMS, by the national associations for long-term care that visitation should be essentially ended as a way of trying to protect residents and keep keep the virus out of facilities. And that has created its own health problems, which we're all very painfully aware of. It was an important strategy to try to slow down the spread of the virus into these facilities. But of course, it came at a terrible price. And most of the cases actually have come through staff exposure in the community and staff bringing the cases into the facility. We could talk at greater length about that, but we've have evolved the guidance from both the federal and state levels to create more visitation opportunities for long-term care. But then when the cases started to surge, that those expanded visitation options were among the first things to be restricted. So we're all eager to see community cases come back down and be able to get back into that zone where visitation is possible, because we know what an important health issue that is as well. The next few slides I'll just skip past, but I think this one's pretty. Go back one. Thanks. This one is worth just you're being aware of, and it really speaks to the the fact that important progress has been made in this sector. This is the whole course of the pandemic. The weeks on the bottom there are they're referred to as MMWR weeks. CDC, it's kind of the calendar for disease reporting across the country. So these are weeks during the pandemic, and the gray line there is the total cumulative Minnesota cases, and the blue line long-term care. And just as a matter of numbers, long-term care has been a small part of the cases since in the early days. It was a large part of the cases, but as the pandemic grew, long-term care has remained quite flat in comparison. You see that big dramatic spike, which started to happen in late October and through November, And I think it's pretty remarkable that at the time that the state was exploding, long-term care was relatively more stable than the state on a percentage basis. But as we knew it would, that spike in community cases also triggered a resurgence of cases in long-term care, which is what you see in the blue line. And while it doesn't look as dramatic, those are big numbers in the long-term care population. So that was heartbreaking to see all that hard-won progress kind of being overtaken by community spread with infection getting back into these facilities. We can skip by the next couple of slides, but these just sort of show you that some of our data, the fact that deaths as a percentage have stabilized since early in the pandemic. And go to the next one, Lisa. And this takes us then into the focus on vaccination, because we know that this is the bridge, this is the way, to the end of this pandemic. So Chris Erzman, who leads our infectious disease efforts and is leading on the vaccination front as well, will talk just a little bit about the bigger picture of vaccine prioritization, but focus on kind of where long-term care populations fit. Thank you, Chris.
Great, thank you, Commissioner. So I'll go very quickly because I know you had a goal of 9:15, but just to reiterate that we're working through the period where we have limited doses available, and because of that, we're taking a phased approach to vaccination. Next slide. I just want to use this to set the stage that beginning in August, when all states were doing their planning, we were planning on phase 1A, including only healthcare personnel, and then subsequent phases, including essential workers and elderly adults. And it wasn't until December 1st that the ACIP voted to include long-term care in the first phase, which we thought was fabulous. We had been lobbying for that. But just to let you know that in terms of planning, we did not know that long-term care would be included in the first phase of vaccination until December 1st. Next slide. And there have been a number of changes that have been made to the guidance, even as we've been moving through. So you can see we added long-term care residents, and then phase 1B was going to be essential workers, but that has been changed to frontline and persons 75 years of age and older. And then phase 1C has added in some of those subsequent essential workers. Next slide. I just wanted to give you sort of the background when the ACIP was making their decisions about ethical principles and making decisions about vaccination. So for the 75 years of age and older folks, this is, in terms of maximizing benefits and minimizing harms, this is the group with the highest burden of COVID morbidity and mortality. Some of the things that they said were, the importance of reaching out to those who experience barriers for access to care, acknowledging the multi-generational households, and recognizing that racial and ethnic minority groups are underrepresented among adults 65 and older. In Minnesota, looking at the 65 and older population, it is 95% white, 1% Hispanic. Next slide. So in order to help us, because we knew that we would have such a problem with limited vaccine supply, we did bring together an advisory group. It was formed in September of this year, so we could start having conversations about these things before decisions were being made at the federal level. The goal was to take the federal guidance and develop principles for Minnesota and make decisions for Minnesota. The advisory group met for 3 meetings just to kind of get their feet wet. And we published our phase 1A guidance on December 8th. Next slide. This is just a list of the membership. I just want to point out that Doug Beardsley is a member of the committee representing elders, and we have a number of folks representing other healthcare and diverse communities. Next slide. The principles that the group was looking to focus on were maximizing benefits and minimizing harms, as we said, promoting justice, mitigating health inequities, and promoting transparency. And so that was the backstory. Next slide. One of the things that they did consider, this is something that CDC put together, it's a social vulnerability index. And it does look at 15 census elements that focus on SES, household composition, disability, minority status, housing type, and transportation. And what we know from the data are that counties with a greater social vulnerability were more likely to become areas of increasing COVID incidence, and social vulnerability is associated with higher case fatality. Next slide. So that was included in our thinking. So what we did is we were looking at sub-prioritization. We looked at the CDC guidance. We looked at what other states were doing. We looked at data from our own healthcare workers and what we were seeing with COVID. And then we considered risk of infection, risk of severe morbidity and mortality, risk of transmitting to others, and risk of negative societal impact. Next slide. So this is what ACIP determined or voted on. This was the level of granularity that they provided. The next slide takes you, if we can go to the next slide takes you to where Minnesota made this more granular. So as you can see, we divided into 3 tiers. The first tier, so the most at risk, included the staff of our skilled nursing facilities and nursing homes. So all personnel, not just licensed staff. And then it included residents in these facilities. Next slide. For the second tier, we move then to those in assisted living. So just including the staff and the residents, and just including our Minnesota definition of that. Next slide. And then in the third tier, we focus on adults living in intermediate care facilities, other elders living in residential care, and adults with physical disabilities as well. So that is how we have prioritized vaccination. So our elders in congregate care settings are the highest priority. Next slide. Now, in terms of how these facilities will receive vaccine, the federal government developed a pharmacy partnership for long-term care program so that long-term care facilities had to indicate whether they would prefer to use this program or go through another pharmacy. And in Minnesota, 210 of our 364 skilled nursing facilities chose to participate. I will say that when we learned that ACIP was including long-term care, we did work to get some of the facilities out of this program. I'll explain why, but our goal was to make sure that we had a broader base of vaccinators. We were concerned about bottlenecking with the limited number of vaccinators that were going to be part of this program. And we are working to arrange vaccinating partners, local public health, and local pharmacies. Next slide. This program is helpful to facilities in that it schedules and coordinates clinic dates. They do 3 visits over 2 months so that there is a chance for people to think about, for staff to think about vaccination. And then if they have questions, they certainly can get vaccine in the 2nd or 3rd doses. And then they do some of the detailed logistic work. Next slide. But there are definitely challenges with this program. We had to push the button to start the program at least 2 weeks in advance, and we've had to reserve 50% of the need in advance before the program could begin. So you can see on the 3rd slide, we had to set aside 85,200 doses of Moderna vaccine for the program, even though they will not all be given at once. And in total, before this is done, so this week's allocation and next week, we will have set aside 152,400 doses of vaccine in this program. And so that's vaccine that isn't accessible for other things and will be used for these populations, but just as a note of explanation. And because of the cold storage requirements and the level of specialty for storage and handling for the Pfizer vaccine, we did use Moderna because we can do that in 100-dose increments, which is allows us to be more nimble in greater Minnesota. Next slide. So just to let you know, the first shipments of Moderna arrived the 23rd and 24th. So that really kind of limited what could be done that first week due to the holiday. CVS, Walgreens, and Thrifty White, who are the providers through the federal program, started vaccinating the week of the 28th. as well as the partners that are, local public health and local pharmacies have also started vaccinating. Next slide. So this is just telling you that, the different proportions. So 114 facilities are going with Walgreens, 117 with CVS, and 54 with Thrifty White, with 84 matched to local pharmacies. And we are making sure that we do have a feedback loop so that if we are hearing about concerns and lack of information or lack of feeling like they have clear information about the vaccine's risks and benefits, that we can provide that. Next slide. I know that there's been a lot of conversation about, oh, we're not getting vaccine out fast enough. Just a couple of points on that. I want to acknowledge that just a month ago, we did not have any vaccines even approved in this country. So it hasn't even been a month since vaccine was approved for use in the United States. And most of our providers didn't even receive their first vaccine until December 18th. So when we think about what's been achieved in light of 2 holidays and limited time to vaccinate, it's really quite amazing. This is how Minnesota looks in doses administered per 100,000 for states with similar population. Next slide. And then this just looks at the percent of doses administered in Minnesota based on our allocation. And I will say that the allocation does not include the PPP doses, just to be clear, and the doses administered does include some from our federal partners. Next slide. At the time that we put these slides together, we were 16th in the country in terms of our doses administered. I want to point out, however, that some of the states that are above us, like South Dakota, North Dakota, Maine, Montana, are very different in makeup than us. Really, Tennessee and Colorado are more comparable. Next slide. And then here, this is percent of all doses administered 20th. Next slide. So we will be moving on. We have gotten enough vaccine out for all of the first tier acute care healthcare workers. For phase 2, we expect that by next week, we should be starting with vaccination of assisted living facilities. This also includes dialysis centers, and we're working to begin vaccinating there as well. So that's just giving you some information about the second phase where we're at. Next slide. Just to say that the Veterans Home has started vaccinating residents, and they started the week of New Year's, and they're finishing this week. They've had good response from staff and residents, so that's positive. Next slide. And then this just provides you with a summary of where we were at in terms of doses administered already in our skilled nursing facilities. I can tell you that, again, this is outdated based on the fact that we had to get our slides in early. So we are now up in the range of 7,400 doses administered, and about so 7,400 doses administered at this point. So we are making sure that people are getting vaccinated. Next slide. Then you've been interested in what happens next. So ACIP, this is how they have laid out phase 1B and 1C. As I said, phase 1B is persons 75 and older, and then these frontline essential workers. And then phase 1C, persons 65 through 74, and then people with underlying medical conditions, as well as other essential workers. Next slide. And so what we're doing in terms of phase 1B vaccination, our vaccine allocation work group met last week, December 30th. We've added some additional members because of the emphasis on workplace. They are working to help with sub-prioritization, and we will be meeting on Monday to formalize and make recommendations related to sub-prioritization. Next slide. But just in terms of, the particular area of interest to you, which is 75 and older, that is really the focus is preventing morbidity and mortality. Next slide. And it's very easy in terms of a definition. We anticipate that there will be vaccination through health systems and medical homes. We want to make sure that we're targeting dual Medicaid and Medicare eligible individuals because of the much higher risk that they experience. And we also need to make sure that we're doing special outreach in communities of focus. So we're beginning to plan for that, although, as I said, we have not fully put out or I guess solidified the phase 1B recommendations. Next slide. And our anticipation is, based on our current weekly allocation, that we should be able to begin phase 1B in early February. But really, this is totally dependent on the federal vaccine allocation that we receive. And for the last 2 weeks, the Moderna allocations, probably 75% or more, have had to go to the PPP allocation. I do want to acknowledge that phase 1A will continue with second doses into February. So when we talk about moving on, there will still be second doses administered, but we are hoping that we will have had sufficient allocation to have provided first doses. And then that's the last slide, I believe. The only other thing that I did want to comment on, because I have heard it quite a lot, and I've heard it in the media and from other elected officials, is a concern about, wait a minute, how come this other group seems to be being vaccinated before our elders? So just want to explain a couple things. One is that in the tier 1 group, it does include emergency medical services. So that does include, EMTs. There are some firefighters and police who have that certification, and it's part of their role to provide medical care. And so that is a group that was in the first tier for vaccination. So I've heard about firefighters and different groups. Just want to explain that, and I can put in the guide or in the chat our specific guidance about that. And then the other piece is just that when vaccination is taking place with the various products, with Pfizer, once you reconstitute it, you have 6 hours to use it. And what we've heard is that there's situations where they're working their way through the list of people who have signed up to be vaccinated. They realize, okay, we now have this many doses reconstituted. They're going to expire in 15 minutes, and they're pulling people in so they don't waste doses. And we have told our partners that is okay. Our focus is our priority groups, but rather than just waste a dose, get it into somebody's arm so that we're utilizing those doses. So that has happened. And so I just want to acknowledge that sometimes you'll hear a one-off like, well, how come the IT person got this dose? It doesn't mean that they were necessarily prioritized to get the dose, but it's likely that they got it because they had an extra dose that they didn't want to waste. So with that, I will stop and turn it back to you, Senator Housley.
Thank you so much, Ms. Erzman. Thank you for that explanation at the end of that, because I was just talking to someone yesterday and they said, we had no idea we were getting the vaccine today, but also when they showed up and said, here, we're giving you the vaccine, but I bet it fell into that case of they were expiring quickly and they needed to get them into somebody. I think members will start with questions on the vaccination and then we'll move to testing since we just finished up with vaccination. I have one question here, which it was an IT person that did get the vaccine. When the healthcare facilities get their vaccinations, is it for everybody under that whole like Alina umbrella or Health Partners umbrella? Anybody that even is a clerical worker that doesn't have any access to the public or patients? Is it everybody? And how is that, what's the oversight of that? Do they ask for so many doses and they get to decide what to do with them? Or is there criteria that you give them that they need to be following?
Senator Housley, I did put in the chat the guidance that we have, and it's a little bit more detailed, but I can tell you that, for instance, in tier 1, what we've said for hospitals is all personnel working in dedicated COVID units, ICU, emergency departments, designated COVID, urgent care. Now it does include, not only nurses and doctors, but also, the nursing assistants, environmental supports, but we've been fairly specific. And then in the second tier, we say all personnel providing direct patient services or handling infectious materials. And then in the third group, it's all remaining healthcare providers. So that is the guidance that we've provided. And we've been very clear that if people can work from home and things, that they should not be receiving vaccine. But we do put the vaccine out to the health systems and have given them the guidance, and we're counting on them to follow that guidance.
Thank you. I don't think all of them are following it, but I won't call them out specifically, and that's on them. And I've also heard people at the University of Minnesota Dental Clinic that are getting vaccines. Were they in the 1A?
No, I can assure you, and
They would be in tier 3, right, Chris?
right. And full transparency, my dad was a dentist. I'm all about, and he taught at the university, I'm all about the dentist, but no, they would fall into tier 3. They would fall into that other healthcare worker category.
Okay, and then one more question, and then I'll go to Coran, Abler, and Hoffman. So when giving out these vaccines, you're going to the nursing home facilities first. I think that's the way I've understood it. But what I've heard from the residents and the facilities themselves is, if you're going into one of the large campuses, wouldn't it make more sense to, do the assisted living, the memory care, the independent living at the same time as you're doing the nursing home? I know the vaccines might be coming from 2 different places, but it seems to make sense to do one campus in one fell swoop. It would get that one, everybody with the vaccine. And then also I think that would be more cost effective. And I know this is probably the vaccine advisory board that said it this way, but I know other states are doing it differently by doing the whole campus and all of the folks. So is there a reason? Go ahead.
Senator Housley. So we are starting with skilled nursing because that is the highest priority and they are at the greatest risk. We anticipate that in the next week, we will be expanding to assisted living. And so then that will be a possibility to kind of do a whole campus at once. But we did want to make sure that we were getting vaccine to the highest risk individuals, because if you look at just the sheer numbers, the number of individuals in skilled nursing is a smaller number. And so we wanted to target them first. When you get to assisted living, it's pretty huge. And we wanted to make sure that, like I said, that we were at least starting with a focus on our most vulnerable elders. But yes, we are kind of adapting as we go to be more flexible, but that was the rationale, was that these are the most vulnerable and they should get the first vaccines.
Thank you. Senator Coran.
Thank you, Madam Chair. I tried to raise my hand in the middle of the presentation, but it was really around the preparation and what we provided for backup planning and staffing for our nursing homes in the middle of the pandemic when we started to see the mandatory testing and the staff all end up to be quarantined. I think you may remember consistent conversations with me in every committee engagement we've had, and as well as commissioners of the Department of Human Services. One of our primary responsibilities, or your agency's responsibilities, is to always be prepared for epidemics and pandemics. We know what occurred in 2009. Now we're in the 2010 version of coming off another pandemic, or at the end of one, hopefully. I'm serious, and I want to know what your plan will be to make sure we're not in this position again. Because I think if you look at what we've done, or what I've proposed in training of staff, certification of all staff in the Department of Human Services, Department of Health, have them be certified at the lowest level, CNA, DSP, PCA. We've had the same issue in group homes, our most vulnerable again, in staffing challenges. We have between the State Department of Human Services, Department of Health, and the county department of the Department of Human Services staff within our counties. We're talking about thousands and thousands of people who should have been certified and be prepared for backup. One, they should have already been providing or being aware how those services are provided. But I look forward to what that plan will be. I have a committee, I'll do a co-plug, a committee on reform. This is the very thing. If we don't do this, and take action, we won't be prepared. It's one of the core responsibilities of your agency and Department of Human Services to always be prepared. And so it starts with the transformation of how we train and certify every staff that we have today. So we're never in this position of hopefully grabbing some federal resources, some other people to try and train when they just don't exist, or the National Guard. It's been a core responsibility. And so I know you remember our conversations. And so I really look forward to what that plan will be and working and helping you create that to make sure that we're never in this position again, regardless of whether it's a smaller scale epidemic and or a large scale pandemic, because we know it will occur, we just don't know when.
Thank you, Senator Curran. I don't know if Commissioner, you want to respond or.
I'm kind of freezing up a little bit here. I don't know if you can hear me. I think I got, Senator Curran, the gist of your point. And I let me just say, I agree. If we don't really take stock of what we've learned from this pandemic and talk about some of the systemic changes that need to happen in the industry and in our regulatory approach, the staffing crisis in this industry is, as you well know, something that's very long-standing, has only been deepened by this experience. And so figuring out how are we going to build up this workforce and train it appropriately is, I agree with you, it's an absolutely core question. And we need a lot of partnership, obviously, with the field and with you to figure out how do we pandemic has just underscored the heart.
Thank you, Commissioner.
Madam Chair. Madam
Senator
Chair.
Curran.
Thank you, Madam Chair and Commissioner Malcolm. This is the very thing that I started the conversation 4 years ago. If we were to begin the basic steps of that, if we think we're going to be solving this from some external environment, they're important, but we have to first start in our own backyard. It's a core responsibility of your agencies, and I look forward to making sure that that happens, or we get those things in place so we're never in this position again. Thank you.
Thank you, Senator Curran. Senator Abler, you have a question.
Well, thanks. And I have many, but I'm just going to ask one. Haven't changed. And I'm looking forward to not having Zoom, where, if a person's at the table and they freeze up, well, that's something else because it's a hard question. But at least if, their communications and, I can't look sideways at you and what do you think? And all the hand gestures we've done in the past. And so anyway, here we are. And so just a comment about the workforce while we're here is that this is really a problem. But the bad news is the nursing homes have the most money of anybody. When you look through the whole service system for long-term care with disability services and so on, they even have less money and less. So, this is a challenge we'll have to talk about more in other hearings. So Commissioner, thanks again for your work. And I'm an admirer of your efforts and I think a loyal just commenter when I see challenges. I've been working with your staff to try to get some clarification about what the criteria were for having a good nursing home was, and one of them was to have like signs saying wash your hands, and then we talked about that. I thought maybe they should actually be washing their hands, and so I'm trying to get clarification from your staff about what was it then and what is it now, and how many sites are complying with your updated guidance on what they're supposed to be doing. And I know you haven't got enough staff to even track all that, but I'm looking forward to hearing about that, and there'll be other opportunities to discuss that. But I think it's really important as a core thing, and if you want to react to that when I ask my other question, you can. But I just wanted to comment that I'm very concerned about that and this battle plan and the governor's good intent and your hard work. It's the local sites do have a responsibility to do things, and people should know, Madam Chair and others, that some places simply are not doing a very good job of their thing. But since I promised only one question, that's kind of my preamble comment. So this might be from Ms. Erzman or Dr. Erzman. I'm always concerned about adverse reactions to any vaccine. The politics of this are such that it's everybody's silver bullet and it's going to solve everything. As I read online, some people have died from this, and I'm sure you're tracking that. So can you I'll give you a chance to offer your comments about that in a formal way, and I'm not going to push any harder on that after that. But if you can besides my arm has a rash, what are you seeing in terms of side effects? I think these are being tracked better than other vaccines, which I think is a good thing. So I'll leave it at that. Dr. Erzman or Commissioner, whichever.
Dr. Erzman?
Thank you, Senator Housley and Senator Abler. Yes, we are tracking adverse reactions, and Senator Abler referred to VAERS, the Vaccine Adverse Events Reporting System. That is a longstanding federal system that does track any and all information about what happens to people after they're vaccinated. In addition to that, there are ongoing post-licensure studies that are being conducted. So looking at what's happening post-vaccination to see if there are any signals. Is there anything that we see when we pull all the data together at the national level that would say, hey, we need to be concerned about this particular piece of information? If you're interested, I could, I'll pull up a slide I have and try and post it in the chat that looks at when we look at both the Pfizer and the Moderna vaccine, the Pfizer vaccine, well, both vaccines indicated a large majority of the recipients had what are called local reactions. So soreness and redness at the site. 80 to 90% of people indicated that they had that. And then more in the 50 to 60% indicated that they had what are referred to as moderate systemic reactions. And what we mean by that is, low-grade fever, fatigue, muscle aches, headache. Just what my parents used to say to me was, you're feeling punk. I don't know if that's an official term for anything, but that's what I used to get told when I just didn't feel great. And that is what has been reported post-vaccination. And the key there is that is an indicator that your immune system is working, that that your body is responding to the vaccine. So although you do feel punk, it does send a positive message that the vaccine is working. And then very severe adverse events were extremely rare. So I will get those slides for you, and we'll either post them in the chat or Lisa can get them to you.
Thanks. And Madam Chair, and I'm not going to belabor this much, just to offer a short comment. We've had many discussions over the years, Dr. Erzman, about VAERS and how it's not even used very well. Is it being used more in this system? Because I believe it was under 1% of the doctors were reporting they were screening out reactions themselves, saying, oh, it couldn't be that, so they're not even turning them in. So the epidemiologists didn't have, bona fide data, and for their goodwill, they tried, but they didn't have the data. Are we upgrading that in this matter?
Dr. Erzman?
Senator Housley and Senator Abler, yes, in fact, it's being evaluated daily, and we are looking into it on a regular basis as well. And just to be clear, all providers are expected to report to VAERS, and they did sign an agreement when they became an enrolled provider. So that is an expectation that they do that.
I'll leave it at that. Thank you, Madam Chair.
Yeah.
Thank you. Senator Hoffman?
Thank you, Madam Chair. Thank you, Madam Chair. And thank you, Commissioner and Doctor, for giving us that overview. And there's a couple of things that I want to highlight and then ask for some action on. And it prompted, thank you, Senator Curran, and thank you, Senator Abler, for highlighting that, the PCAs, CNAs, DSPs, people with disabilities, that vulnerable population. When you look or read something, the optics are that's never really talked about except as an aftermath. And so I'm glad you guys are bringing that up, and I'm glad you're here to hear that conversation, which also falls in line with when you look at slide 36, and I have a few that just prompted this. Slide 36 talks about the transportation. Slide 24 puts transportation providers in the 1B category. Slide 28, you talk about mitigating the health disparities. And I want to focus in on, there's a non-emergency medical transportation provider who is providing COVID. They've signed up to provide COVID transportation. And it hits those three slides that I just talked about, specifically on mitigating health disparities and the vulnerabilities. If you look at slide 29, you talk about the vulnerable populations of vulnerabilities. And so I have a non-emergency medical transportation provider who isn't even in that 1B or 1C category, yet health partners, MTM, and UCare are utilizing them to transport positive COVID people from long-term facilities, group homes, elderly, and these are our aging population, and a large majority are Medicaid. So they're fitting that cone of vulnerabilities, Commissioner, that you talk about, yet they're not even listed. Those transportation providers are not even listed within the 1B or 1C category. And I believe that they should be. And so I guess the question is, if we are saying to somebody, here, do a non-emergency medical transportation, and you've done positive COVID provide transportation, we need to get you some protections in place. What's the strategy to make sure that an organization, and I'll give you the one, is the Blue and White taxi company that I know within the metro area, and they're hitting all those. They're providing transportation to 25 to 30 COVID positive people per day. And so what's the rollout to get those folks elevated, not just into phase 3 or phase 4, but rather in the 1B, 1C category?
Commissioner or Dr. Erisman?
Madam Chair, Chris, could you speak to how very specific cases like that can get reviewed?
Yep. So just Senator Housley and Senator Hoffman, just to clarify, when you saw in that table that included transportation later, that is the whole transportation sector. So that is, yeah, in 1B, it includes like mass transit providers. So what you're describing is really something that is more akin to almost an ambulance kind of situation where we have made provisions for vaccination. So what I would say is that's a situation where we need to reach out to the health systems that are using these providers to indicate that, yes, this is a key part of your system, and these are people that should be considered. So the intent was not to miss this particular group, because we have included other providers who are transporting patients, albeit in a more urgent manner. But nonetheless, you're bringing up an important point. But I do want to just make the distinction between the transportation sector versus what you're describing here, which is transportation within healthcare. So we can connect about this.
Senator Hoffman.
Thank you, Madam Chair, and thank you, Doctor. Who should I have somebody contact somebody at the Department of Health? Because you mentioned the two healthcare providers that would be Health Partners and UCare, both saying that these are critical transportation moments, that they're taking, they're going out there and doing things that need to be done. And so is that do you want me to give that person to you? I mean, your plate is full, but who or how should we get those folks connected so that they are elevated to that heightened? And I'll tell you this, the majority of folks they are providing transportation for, Indigenous, elderly, Somalia, I mean, they fit all your categories of mitigating those health disparities that need to be there. So who or what or when?
Dr. Erisman.
Senator Housley and Senator Hoffman. So a couple of things. One is we can make sure that we're reaching out to our health systems to say, hey, you're going through your list of people to vaccinate. Have you forgotten this group? This is an important group. We want to make sure that you're considering this in your planning. And then second, I think Lisa can connect with you, and we'll get the information, and we'll work to make some connections there as well.
Thank you. Senator Eakin, you have a question.
Yes, thank you, Madam Chair. Actually, just two questions here. One, dealing with the Senator Abler brought up the issue of vaccinations and any negative effects that they may have, which is important because we want to make sure we're getting this right, because we need people to have faith in the vaccine in order for it to be widely administered so that we get that herd immunity that's so critical. Have you encountered much resistance from people who are concerned about it? That's a concern of mine, is that if enough people are unwilling to take the vaccine, that we're not going to be able to achieve the results we're seeking here. Are there workers, for instance, who are saying they will not take the vaccine in nursing homes and other long-term care facilities? Or are there problems with residents. And obviously dealing with long-term care, you've got people with dementia and other issues that make them incapable of giving consent themselves. So you often have to work through the families in order to receive such consent. I'm just wondering what kinds of challenges you're facing in that regard, if you've got much feedback as far as resistance on that. And then the other question I had was in regard to the different tiers and the priorities, and you're describing, for instance, nursing homes, long-term care facilities that are in tier 1. Tier 2 would include, I guess, the assisted living. And you mentioned tier 3 being where those with disabilities would be. But I was wondering with, for instance, group homes, is there are the morbidity rates, I guess the threat that COVID poses to that population, is that similar to the threats that are posed to our senior populations in nursing home settings, for instance? And if that's the case, should they be in a higher tier? I'm just curious as far as, I guess, how people in the disability community are affected by this.
Commissioner?
Madam Chair, Senator Aiken, and I would ask Chris to give a more specific answer here, but first to your point on vaccine hesitancy and in general, and concerns about these vaccines in particular, it's so important that we do, as you say, build trust in the public. There have been a lot of questions about how quickly these vaccines were developed. I think Chris has done a great job in our media briefings and so forth, trying to explain that the safety protocols, the rigor of the trials and the analysis were the same for these vaccines as everything else. So we do have a job to do to help educate the public and reassure them. We think it's going to be really important that trusted members of the community be the ones doing this education. So it's not just us from a public health perspective, but trusted community leaders. And Chris can speak to what we've seen so far. Certainly some folks, even healthcare providers, preferring to see more data before they are vaccinated. They're not saying they won't be, but they're interested in longer time frame of data. But generally, really enthusiastic response by residents.
Oh, she froze.
Here and the state has been a little more variable. But Chris, do you want to speak to that a little more clearly?
Sure.
Dr. Erisman.
Senator Housley and Senator Egan. So a couple of things. Yes, I mean, one consideration I mentioned with even the PPP program is that they will come to a facility 3 times with the idea that, they'll vaccinate folks who are eager and willing the first time, give the second doses the second time, but could also do first doses if somebody has said, now I've had a chance to think about it and I want to be a part of this, and then a third visit to finish up second doses. So even the planning for some of these programs acknowledges that we anticipate that people may want to have more time to think about this, and we certainly want them to have that. That is something that we're going to be tracking and looking at, is to see what are the concerns that people have and what can we do upstream to help provide them with the kind of education and information that would give them confidence to be vaccinated. And then to the question of group homes, yes, I mean, we have a team that has been working with group homes, doing the same things that Assistant Commissioner Rydrick mentioned that we've been doing for long-term care. We have seen cases in those settings, and that's partly why they're in tier 3, but we have not seen the same level of mortality and severe disease that we see in our assisted living and our skilled nursing facilities. So they definitely are included in this very first group of prioritization, but we have prioritized within that, just simply again because we don't have sufficient vaccine for everyone that wants it at this point. So we've had to prioritize, and we're doing that based on what we know about morbidity and mortality.
Thank you. To follow up on Senator Eakin's hesitation with the vaccination, I'm hearing from some of the caregivers in the facilities that they're hesitant because if they're still going to have to continue to get tested 2 times a week, why would they get the vaccine this early on? Is there any assurance for them that after they get the vaccine twice, they won't have to continue to get tested? I don't know who wants that one. Dr. Erzman?
Yeah, so Senator Housley, yes, unfortunately, they do still have to get tested. And I'll just explain the rationale for that. The reason is that the clinical trials that were done for these vaccines used clinical disease as their endpoint. So what that means is that the data that they collected and used for all of the approval process looked at clinical disease. And so because of that, and because of the strict way that we are careful about what we say about what data tells us, we cannot say that we have evidence that the vaccine prevents against asymptomatic infection. Now, I want to be clear that from a practical biologic standpoint, it seems pretty likely that if a vaccine is going to keep you from getting clinical disease, probably the same physiologic process would keep you from asymptomatic disease, but because we don't have that data, we can't say that. So all the guidance remains in place. However, we are looking, and by we, I mean at the federal level, we are looking to see now that vaccine is being utilized. Does that mean that we can, we'll see a reduction in transmission, and we can use that data to then make subsequent changes? And just to be clear, in terms of hope for the future, when we get to the point where we have a large proportion of our population vaccinated, 80% of the population vaccinated, and our disease transmission is, significantly reduced, we will get to the point where we don't need to do masking and social distancing and all of those things. So I don't want to cast a pall of gloom to think that, yeah, we got a vaccine, but we still got to wear these masks for the rest of our lives. That's not true. But right now, in these first months post licensure, that's the reality. But you're right, that I can see where people would say, if I'm going to get tested every 2 weeks, maybe I'll pause. I'll take a pause.
Just a quick follow-up. If let's say an employee at a facility got COVID and got over it and came back, do they continue to get tested even though now they have the antibodies? Or I always keep thinking, wouldn't there be an easier way that you could put them all in a group of those that have antibodies that don't need to be tested, and then just test the group that don't have any antibodies that still are susceptible to getting the virus?
So Senator Housley, in terms of once someone has had COVID, then the guidance from CDC is that they have 90 days in which they're considered to have strong protection. And so they don't need to be quarantined. They don't, it wouldn't make sense to test them. They're good for 90 days. And in fact, they're even looking at whether or not that should be extended to 6 months. But yes, once you've had COVID, you do get a little bit of a break there.
Okay, that's what I was wondering. Okay, good. So before we go, because we don't have a few minutes left, what's the overall timeline? Because I did hear from one of my friends who's 68, her and her husband live in their home, and that's the couple that called their primary care physician, who said, I have no idea when you're in the pecking order to get it. Just keep checking your newspaper, which is not a good thing to tell a senior who's been, tightened up in their home for all of this time, and now they see the vaccine and they don't see where they are. When can they get it? Is it May or is it February, or what's the timeline for starting with where you are, then the assisted living, then the independent living, and then right on down to the 65-year-old? Where are they in this pecking order? What's the timeline?
Well, Madam Chair, and I'll turn this to Chris in a sec, but I think just again, the variable we have no control over is what is the volume. The Minnesota spigot is there, it's ready, but at this point we're getting only 65,000 doses a week. At that pace, it's going to take us quite a long time to get all the way through 1C, which is where the 65 and over population would be. So that, I don't have a precise time estimate for you, but I think, best case, we're hoping not only that the production might ramp up, but that additional vaccines will be approved early in the first quarter, and that would really change the picture of how quickly we could ramp up. But we certainly do intend, and for each stage that we're in, very specific communication strategies to let people know, where they are and what's coming. At this point, we're just trying to describe the sort of the general sequencing and asking people to be patient. I know that's not a very satisfying answer, but Chris, I don't know if you at this point,
yes. So Senator Housley, we anticipated that there were about 500,000 people in phase 1A. And so we're anticipating that we would have received that much vaccine by the end of January. So that's why we're thinking that we could start 1B at least by February. So that's one thing. And then really, as the commissioner said, it's really dependent on our allocation. Right now, as I've mentioned, a huge portion of our allocation is going to this PPP program to make sure that it has everything it needs. Then once that's been taken care of, the vaccination will continue, but the allocation that we get will be able to be distributed more widely. So that will make a difference. But as the commissioner said, we are really looking to having additional vaccines approved, because that will make an amazing difference in the volume of vaccine available. I think to the questions that have been asked about concerns about hesitancy, I think the really happy news for us right now is that everyone wants to receive the vaccine. But it's also stressful because we can't make as much vaccine available as there is interest. And that for someone like me, and Senator Abler knows that given our background on vaccine issues, he knows I care very much about vaccine. And so the fact that we have people who want to get vaccinated and we can't get them the vaccine quickly enough, that's really hard for us. So we're going to continue to work on that, and we're moving to get as fast as we can, but it is the supply that's the challenge.
Thank you. Members, are there any other questions? All right, then. Commissioner Malcolm and Dr. Erisman and Diane Rydrick, thank you so much for your presentation today. We're gonna have you back, I'm sure, in the near future to get an update, because it's changing every single day with the new news coming and more vaccines and more questions. So I want to thank everybody for being at the committee and all of those listening and watching, and thank you for all you do at the department. You guys are. It's been a long 10 months, and I'm sure we've still got some difficult ones yet to go. So I want to thank everybody for coming, and I look forward to seeing you guys again soon. Next Wednesday, 8:30, same time, same place, and hopefully we'll be in room 1200 soon. All right.
Thank you, Madam Chair.
Bye-bye.
Thank you.